So I'll be brave if you're brave. I'll be brave, but only if you're brave. So I'll be brave if you're brave. I'll be brave, but only if you're brave.
Sometimes I can't. Oop. Good evening, everyone. Welcome to tonight's Lung Cancer Living Room. Happy to be here. Thank you all for joining us in the room, and those of you joining us from your own living rooms. I'm Danielle Hicks, for those of you who may not know, Chief Patient Officer here at GO2 for lung cancer. For those of you who also may not know and may be new to this programming, it's really was built with the person diagnosed in mind for them, for their care partners, for their families, their loved ones, bringing to you live and in real time conversations with key opinion leaders about varying aspects of the disease. And tonight, we're really excited to be talking about non-small cell lung cancer treatments, sort of what's happening today, what's happening right now. Probably get in a little bit to what's coming sort of down the pike and how we're treating non-small cell lung cancer. And then we're also going to touch on the importance of education and people being educated and empowered around their diagnosis so that they can have informed conversations with their healthcare providers about what's coming next and what this all means. So tonight we have Dr. Eric Singhi from MD Anderson down in Houston. He flew in this afternoon to come and be with us. And I'm going to read a little bit about who he is, at least in title, and then ask him to introduce himself. But before I do that, I want to remind everybody that we really invite you to ask questions throughout. We do this for you. So there are no silly or stupid questions. Please feel free to grab a mic if you're in the room, and if you're watching online, to type it into the chat, and Michelle will make sure to answer or to ask the question on your behalf. So Dr. Singhi is the Assistant Professor, Medical Oncology Lead, Young-Onset Lung Cancer Program, Patient Safety Quality Officer, Thoracic Head and Neck Medical Oncology Director, Cancer Medicine and Research, Thoracic Head and Neck, MD Anderson Cancer Network, University of Texas MD Anderson Cancer Center. It's a mouthful. And that tells us who he is in title. But what I'd like to start with is who you are as Eric Singhi and why lung cancer is an area of importance for you.
Yeah, well, first of all, thank you for having me. Really excited to be here. Brave the weather. Definitely getting used to a little bit of the cold. I was used to Houston, and it's already warm. It's in the 70s, 80s. But excited to be here with everyone. So as you said, I am a medical oncologist, which means I give drugs to help patients and their families fight lung cancer, right? And I'm involved in research. I'm involved in education as well. I'm involved in different patient safety initiatives at my institution. And so work with patients, work with families, but also work with the next generation of oncologists, which we call oncology fellows, oncology trainees. So really enjoy being able to teach. I have a big passion and focus for young-onset lung cancer. So we were able to start our own young-onset lung cancer program, very specific to patients under the age of 50 at MD Anderson. And so grateful to have that support and partnership for those patients. And so that's a little bit about me and what gets me excited.
Yeah, I love that. And I think you guys have heard me talk about Dr. Singhi before. He's the Lung Onc Doc on Instagram and social media, and one of my most favorite people to follow. As you know, bringing awareness to this disease is an incredibly important part in furthering research and understanding about what a lung cancer diagnosis really means. And he's a testament to somebody who is stepping up not only in treating patients, but also in generating that awareness about what it means to have lung cancer. So we have a lot to cover tonight, so we're going to jump right in. And as I said, we're talking about non-small cell lung cancer. That doesn't mean if you're online and you're a small cell lung cancer patient that you can't also ask a question. So please feel free. Before we jump into some of the more details, can you explain a little bit about what some of the main treatment options are for lung cancer, and then we'll jump into how you determine when to use those.
Absolutely. So when I'm thinking about what treatments we can use to fight non-small cell lung cancer, I'm thinking about 4 different groups. So surgery is one option, radiation generally is another option, and then systemic treatments, that's what I specialize in. Those are medical drugs. And so things like chemotherapy, immunotherapy, targeted therapies, antibody drug conjugates. We'll talk about what all these things mean in a little bit. And I think that 4th tool that's really important is clinical trials, and we're definitely going to lean into that. So those are the 4 tools that we use for lung cancer, specifically non-small cell lung cancer. If you want to think a little bit about those tools and break it down into 2 categories, how do we treat non-small cell lung cancer? I say you can treat it systemically, which means you're treating with drugs that basically go through the bloodstream and they'll fight the cancer cells wherever they are in the body. Or you can treat them locally with things like radiation and surgery. And really you're treating what you can see on scans.
Sometimes we use a combination.
Right, and there's combination therapies.
Right.
Yep.
So how do doctors decide? Let's step back a little bit. So someone's diagnosed, their malignancy has been identified. What happens next to determine what the next best step is or the best treatment for that person?
Yeah, I think one of the hardest parts is a lot of patients, right before they come to me, they've just been diagnosed with cancer. And then they're told, you have this potentially life-changing diagnosis, and now you go see a specialist, and then the waiting game, if you will, begins even more, right? And that waiting is painful. It's painful for definitely the families, definitely for the patient, but also for us too. We're waiting. We're always waiting to get more and more information. But that waiting, I will emphasize, and we'll talk more about this, can be really important, especially for non-small cell lung cancer, because we don't just want to treat lung cancer anymore. What we want to do is treat your lung cancer. We really want to personalize treatments. And so there's a lot of workup that goes into it. And so we want to figure out exactly what subtype of lung cancer you have. We want to understand the biology, what's driving that lung cancer to grow so we can attack it, so we can personalize your treatment plan. We want to figure out exactly where your cancer is, right? So we want to make sure we understand the stage of the disease. And then we put all of that together in addition to your overall health, what are your patient goals, and then we develop a plan together.
I love that, and we're going to talk a little bit about the goals of care later on. So how do treatments differ based on stage?
Yeah, so generally we think about in non-small cell lung cancer early stage disease and late stage disease or stage 4 disease. For early stage disease, really what we lean on if a patient can go to surgery is surgery, right? We're thinking a lot about surgery. And then what we're trying to do is cure that disease, use most of our tools to cure that disease, and then any additional tools that we use to reduce the risk of the cancer coming back. That's early stage disease. For late stage disease, what I tell patients is we're aiming for control, right? So there's cure for early stage, there's control for later stage or stage 4 disease. But that word control, a lot of people worry, they say, oh, control doesn't mean cure. But lately what we've seen over several years now is that control can be long lasting. We're talking control for many years, no longer weeks, no longer months, but years for patients with stage 4 disease. So you want that control to be with good quality of life. And so that's generally how I think about how we're navigating early stage disease and then late stage disease.
Yeah, and I think it's an important distinction, the control versus cure, because I know, I've been talking to patients, diagnosed with lung cancer for 20 years. And 20 years ago those conversations were very different than they are now. And the control piece is so important. And I know people in this room and online, who were diagnosed with stage 4 disease, who a decade or more later are still living well.
Yes.
With the disease. So I think it's important to kind of remember this big old sign, behind our heads here, talking about hope. But it also points back to the importance of being educated and understanding what the diagnosis is and what maybe your options are. Right? You guys hear me talk all the time about. Not everybody has the benefit of a Dr. Singhi who is able to specialize in lung cancer. Things are happening so fast and furiously in this landscape, changes are really happening practically on the daily, it feels like.
Very true.
And so when people, live in small town USA and they're seeing a general oncologist down the street, that he or she is expected to know everything there is to know about every type of cancer that walks through the door. So not only educating yourself, but also looking at second opinions, and I think we're going to talk about that in a little bit too. So I want to talk a little bit about biomarker testing, and not in the not so distant past, we were really only talking about that for people who were diagnosed at later stages, but that has changed. So can we talk about biomarker testing, when and why?
So biomarker testing is truly the name of the game for non-small cell lung cancer, and so if you have not heard about biomarker testing, really, please look into it. Please listen in. This is, I think, a really key takeaway from our conversation tonight. Bring it up with your oncology team. Do not feel ashamed or embarrassed to ask anything about biomarker testing, genetic testing, molecular profiling. There's a lot of different names for it. So biomarker testing is really an opportunity to personalize your treatment for non-small cell lung cancer. And we do it in a few different ways. So biomarker testing can be done the traditional way is by getting a tissue biopsy where your oncologist will refer you to another physician to go and get a sample of the lung cancer cells. And that way, once you have that sample, and hopefully enough of that sample, you can run all these different tests to understand why is the cancer growing the way it is, really understand the biology of the cancer. And we're looking at certain DNA changes, the instructions of those cancer cells to say, what's going wrong? Why is the cells growing out of control, unlike what they should normally be doing with very regulated control, right? Then you can also have a liquid biopsy or a blood test. This is a non-invasive, depends who you ask based on the blood test. I don't like getting stuck with needles. I actually look the other way. But, they call it non-invasive, but basically it's about 2 vials, and it's a blood test where the thought is sometimes the tumor is shedding a little bit of its DNA into your bloodstream, and we now have the technology to separate out your blood, separate out potentially the tumor's blood, and start to look for some of those DNA changes that way. And that one comes back faster. So there's 2 different methods. There's also different types of sort of how extensive molecular profiling is or biomarker testing. And so you not only need to know, did I get biomarker testing, but did I get comprehensive biomarker testing? So you don't just want a limited panel. You don't just want limited testing. You truly want to have the full analysis done, because if you don't look, you'll miss it, right? And so I think that's really important to emphasize those 2 questions.
And I think just to sort of add on to that, and I know this is not new news to some people in the room. Sorry, we're just doing a little mic check. Is how important that comprehensive is, right? Because we know that there are targets out there that have approved FDA therapies attached to them, but we also know that there might be something in a clinical trial that is not approved yet, but there could be a good option from a clinical trial standpoint to look into that. And then I also want to reiterate or ask you, when it comes to the liquid biopsies or the blood test versus tissue, although we know liquid comes back faster, it doesn't take quite as long, if we don't see anything there, what does that mean for people?
Yes, this is a great question. I see a lot of second, third, fourth opinions. And sometimes, and what I've seen recently is that out in the community, a lot of oncologists order a liquid biopsy because it comes back quickly. It's that non-invasive. They don't necessarily have to call another doctor to arrange a tissue biopsy and wait for those results to come. Those results can take sometimes 2 to 3 weeks to come back, right? But if that liquid biopsy comes back negative, they didn't find a mutation, there was nothing actionable, you can't rely on just that. Because really that test could be a false negative, meaning that there wasn't enough of the cancer cells that were shedding their own material into your bloodstream, and then it wasn't picked up. And so there's a lot of nuances that happen with negative liquid biopsies. And really I would urge you to say, hey, no, I really need a tissue biopsy. I need to get tissue molecular profiling to make sure that you did not miss a target, because it happens.
Yeah, and I think that's another really important distinction. If we see something in the blood, we know it's there.
And we can go with it.
We can go with it. But if we don't see something in the blood, it's important to get the backup tissue test done.
I think you should say, they're complementary, but they shouldn't substitute each other. I think that's really important.
And when should someone have this type of testing done?
Yeah, ideally upfront. I'm a strong believer that every patient with non-small cell lung cancer, regardless of their zip code, regardless of what they look like, regardless of where they're coming from, should be getting biomarker testing. And I'm a big believer that it's not just patients with stage 4 disease, but even earlier stages of disease, even stage 1 disease. We actually have FDA approvals now for targeted therapies for patients with stage 1B disease and higher. I would argue that even stage 1A disease deserves to have molecular testing because that's opportunities for clinical trials. There are clinical trials that are available for patients even with earlier stages of disease, and you won't qualify unless you check for that molecular testing.
Yeah, I think I love that you said that because we often get calls or have conversations with people who are a 1A, and by guidelines, technically, it's not necessary, but you make a really great point with the clinical trials. So,
and I think not just clinical trials, but also, oh yeah, go ahead. I was going to say just not only clinical trials, but also as an oncologist, the way that we treat lung cancer, it's not like checkers, it's like chess, right? Where we want to have whatever the next move is, you want it to be very strategic, you want it to build upon your prior move. And that's the way I think about how I treat patients and how I treat lung cancer. You want to have plan A, B, C, D ready, and I think knowledge is power, and biomarker testing allows for knowledge, and that allows you to truly have a powerful decision for that next attack if you need to pull it for that patient, if unfortunately the cancer comes back.
Yeah, and I think in early stage, let me just finish this thought and then we'll jump over. In early stage, historically, we didn't do it because people were going in and they were having the surgery. And you guys have also, for those veterans to this meeting, have heard me talk about neoadjuvant. So before surgery, are you having some sort of systemic treatment done, or adjuvant after surgery? Because we know even in early stage, there's a way too high a percentage for the cancer to recur or come back without this. And with targeted therapy and studies that were done, we've found that people who are treated either in the neoadjuvant or primarily the adjuvant setting, that seems to be sort of warding off anyway, right, the recurrence. No, you just talk.
No, it's on. I think she mentioned that somehow we could replay all of this, what you just mentioned. Mm-hmm. Is that right? Like another day? And secondly, can this testing be used to see if it's the right time to reduce the medication or even to skip a day with the medication?
Yeah, I think that's a good question. So we're still learning about how to use some of the information, particularly one of the hot topics right now is liquid biopsies and repeating liquid biopsies to figure out treatment decisions, right? We don't have great data yet prospectively to tell us what to do with the information if you can't see it on scans, right? So right now, really the way that we're monitoring things for most patients is using scans. And those scans can be anywhere from every 8 to 12 weeks for patients with stage 4 disease for the most part. So that's really our gold standard for monitoring. We don't yet use liquid biopsies routinely in stage 4 to monitor and make decisions. But I think it's a really great area of research, particularly if we're thinking about patients and thinking about quality of life, dose reductions, dose holidays. Those kinds of things are really important questions. We just don't have a ton of data yet, but I think it'll come.
Sub-question, what's the time frame on what you just mentioned?
On research that's looking into this?
On the research that we could move forward.
Yeah, so there's actively things that are happening right now. So prospective research means that you design it up front and then you go move forward and you look at what the outcomes are. There's also some retrospective data that we have that's already been done where they looked back to see, okay, if there's a dose modification that's done for a patient that's on a targeted therapy, does it impact their outcome? Do they live less because you change the dose? Do they have less control on their current therapy because you change the dose? We have some of that data, actually. Just there's a lot of different studies that have been done, phase 3 studies. I'd encourage you to talk with your oncology team about it and say, hey, listen, is there any retrospective data for patients that had a dose reduction where it impacted their outcomes? Because there is some data for that.
Good. So we've just been diagnosed. We've done biomarker testing, comprehensive biomarker testing. Why is this important? What are you looking for, and how is that helping to determine the treatment?
Yeah, so almost 60% of patients with non-small cell lung cancer, if they've got a very specific subtype called non-squamous, right, which is the majority of patients with the non-small cell lung cancer, 60% of them will have what we call an actionable genomic alteration, or an AGA. That's like the new buzzword that people use, okay? So AGA. So your non-small cell lung cancer can have an AGA, and if that's the case, then you may qualify for a targeted therapy, one that's approved, or one that's being studied on clinical trials, or both, right? And so it's important to know because it really can empower you to make a decision with your oncology team about what's the best treatment, not just for lung cancer, but your lung cancer. I keep saying that because it's a privilege to be able to treat patients with lung cancer today because we continue to have more options and options that are truly personalized for your lung cancer. And we'll talk a little bit more about this, but options are evolving, but so are biomarkers. We're starting to learn about more biomarkers. And that's why, your testing that was done maybe 5 years ago may be out of date, right? And so that's why you need to talk to your team if you have new disease progression or if you're worried that you may need to be changing your treatment. Ask, do I need repeat biomarker testing? Is it truly comprehensive? Is there anything new? Because it's a very valid question to ask.
How does this testing impact whether or not somebody's qualifies or should be on an immunotherapy?
Oh, yeah, that's a great question. So not all AGAs, actionable genetic alterations, are the same. So just because one patient has a disease that has an EGFR mutation, another may have an ALK fusion, for example, or ALK. There can be KRAS, there can be BRAF. It's a whole alphabet soup, right? There's at least 10 different biomarkers right now that we think about. Not all of them are the same, and the reason I'm saying that is because one can be more common than the other, for example, but they can also either respond really well to immunotherapy or not really. And so, for example, some mutations or AGAs like BRAF and KRAS, those can respond really well to immunotherapy. But currently, mutations like EGFR and ALK, they don't respond very well to immunotherapy. And so that's why it's important to really understand that not all of these AGAs are the same.
Mm-hmm. So going back to the question earlier about taking a break, I know, of people, particularly with who have been on immunotherapies, but also some folks who have been on targeted therapies who kind of pull back and say, okay, let's watch and wait. Has that been studied? Has that been researched? Are we looking at that?
Yeah, so I think the duration of targeted therapy is a really hot topic, and then so is the dose, right? Because I have patients that come to me and they're like, why am I on the same dose as someone that's maybe twice my size or 2 times smaller? It just doesn't make sense. When we think about how oncology drugs are developed, it's the maximum tolerated dose where we really push during development, during those phase 1 trials, those phase 2 trials, to really understand, okay, in terms of safety, how much can we push until that safety is really compromised? What we have urged and really asked sponsors of trials to do is once we get the phase 3 data and we're looking and we're understanding the drugs, can they look back and if patients required a dose reduction or a dose interruption, did it impact outcomes? Did it impact really how long patients are living or how long they could be on that drug until they had to change their game plan? And so there's more data coming out, that retrospective data that I've hinted at before, where you can ask your oncology team and say, hey, is anything published yet? Because yes, we're continuing to get updates. That's, I think, the really important part about why a lot of us go to these different oncology conferences that you see all across the nation internationally is because we get long-term follow-up updates. We get updates about, okay, this is how the patients are doing now because they were continued to be followed beyond 1 year, 5-year follow-ups, 7-year follow-ups. And that's where those nuances come in. So then we can come back to clinic. I've come back on Monday. I said, hey, listen, I actually found out that if I made a dose reduction for you, it does not compromise your efficacy. It does not compromise your outcome. I've done that before after ASCO, that Monday after ASCO. I've actually gone back to my clinic and I've brought that information back. So that just shows you how the science is evolving and the data we're getting is continuing.
Yeah, I love that. So we've talked about at diagnosis. What about at progression?
Yeah, biomarker testing at progression. Yes. So, for many patients with non-small cell lung cancer, you want to understand first the pattern of progression. There's different patterns of progression. I'll take a big step back.
Yeah.
For patients that have AGAs or actionable genetic alterations, they can really be on cruise control for quite some time on targeted therapy. They can have a really good run on their targeted therapy. And then, unfortunately, the cancer starts to learn how to outsmart that drug. And it can do it in different patterns. You can have what we call oligo progression. Oligo means few. And so oligo progression means a few sites, 5 or less sites that may start to be popping up while the rest of the disease is well controlled. And so maybe 1 or 2 spots, for example, the bones is a common area, or sometimes even the brain, they start to develop while the rest of the disease is really well controlled. For oligo progression, I would say you may still want to stay on the same therapy. It's actually very reasonable to stay on the same drug but then call in colleagues like surgeons or radiation docs to help handle what's developed resistance, what's growing out of control. So that's oligoprogression. Polyprogression means that many sites, usually more than 5, are starting to grow. And at that time, I'm really thinking about needing to change the drug therapy that my patient's on. I'm really worried that too much of the disease has really started to outsmart the drug that they're on. If that's the case, I want to understand why. Why is this happening? And so I would encourage you to talk with your team about getting another biopsy. You want to make sure, is it the same cancer? Has it transformed to a more aggressive enemy known as small cell lung cancer, which is typically growing faster? That can happen. But you also want to understand and get enough tissue to repeat that molecular testing. I think that's really important because we are able to sometimes find new mutations that explain why is the cancer outsmarting the drug that you're on, and now we have drugs where we can actually target those too. And so really understanding why it's happening and then developing a game plan that's personalized. So another opportunity, even beyond diagnosis, to personalize your treatment.
Yeah.
Don't you get a pushback from insurance companies when you do something like this?
No, we have
Usually
data.
You don't.
We have data to support this. There's actually trials that are designed, and we have data that's come out from those trials that says, hey, listen, if we understand the acquired mechanism of resistance, the reason why the cancer is growing on your current treatment, we can pull in a drug that will work very well. And there's data to support that that method actually does a lot better than using something that's a little bit less targeted, less personalized. And so if you are getting insurance pushback, and it's one of the big frustrations, one of the systemic frustrations in oncology that drives me crazy. I post a lot about it on my social media. But I'm also a big advocate for my patients too. And so your oncology team should also be advocating, showing the data, doing a peer-to-peer, because that's the right thing to do.
It is the right thing to do, and some of you may have seen our living room last month where we had a big conversation about this. We had some technical difficulties with the folks calling in remotely, but there is support out there as well for folks who are getting pushback, and GO2 is one of those support systems. And the people on the other end of our helpline, my colleagues, can help guide you in the right direction when it comes to pushback against biomarker testing, pushback against paying for therapy that your doctor is recommending that they feel, might not be warranted at the time.
Yep.
So there is support, and we can absolutely help if you're not feeling like you're getting that support from your own providers. Yeah. All right.
So, quick question. Back when you talk about staging can very often be understaged as opposed to overstaged. So, how big does a pocket of cells need to be able to be imaged? Is it 50 cells, 1,000 cells, 1,000,000 cells? What does it take to be large enough to be able to see it on a scan, to be able to say it's there?
I think that's a really good question. I don't know if we have the perfect answer for the exact number of cells to be able to detect
Approximately.
but I think you're hinting at this concept of what we call micrometastatic disease and then macroscopic disease. Macroscopic disease means that we can see it on a scan. And you're right, our scans are only as good as the level of detail where we can see it on a scan, right? Microscopic disease means that there's disease that's lurking beyond that. It's small enough, but it's still there. It's typically in the bloodstream. It can also travel through the lymph nodes. So the way that cancer moves around the body, it's really 2 routes, through the blood or through lymph nodes. Those are the channels that the cancer cells use. And it can be really tough to find that microscopic disease. What we're trying to do is move beyond scans, right? So there's a lot of research that's happening. We may talk about this with ctDNA liquid biopsies. The problem with that test right now, that liquid biopsy test, is that the sensitivity is not yet perfect. It's not there. We're pushing it, and it's continuing to get better. And if I'm back in this living room in maybe 5 years, I think we may have even better technology and science to find that microscopic disease. But it's coming. So I think the future of this, maybe yes, our scans and our detail and our resolution will get better, but the liquid biopsies, the ctDNA, I think that's really going to be the most high yield for this.
Right, finding it basically before you see it, before
Right.
it's visible
On
a
scans.
scan.
Yep.
Yeah. Anybody else have any questions? Michelle, quick check-in online. Are we good? So one of the things I also want to touch on about the progression, or if your doctor suspects that your cancer has progressed, and the importance of the rebiopsy at that time. And maybe you said it, and I was looking down and didn't hear you, but it's not just, the potential for an FDA-approved drug for whatever that resistant sort of mechanism is identified as, but it's a great opportunity, too, for clinical trials.
Absolutely. I think at every point in your cancer care journey, you should be asking about clinical trials. One of the biggest myths is that you have to use clinical trials as a last resort, and that is not true. There are many trials for patients who are newly diagnosed with non-small cell lung cancer, newly diagnosed with small cell lung cancer. And some of the most promising drugs that we have are being studied in that setting. And so I would absolutely encourage you to talk at any point in your cancer care journey about clinical trials. There's never a wrong time.
Yeah. Another shameless plug for GO2 support services, our Lung Match team, where we have navigators on staff who will help walk you through clinical trial searches at any time during your journey, and then explain enough about it so that you can then go back and have informed conversations with your providers wherever you're being seen. So, a little shameless plug for GO2 and some of our support services. So, I want to jump into a little bit more of the complexities, right? Because a lot of what we're talking about is a little sort of cut and dry, and we know that that's not cut and dry, like cancer is cut and dry. It's not, right? But sometimes it's more complicated than just, let's get the biomarker testing, we've identified a target, here's the drug, Go.
Yeah.
So when we're talking about how some of the decisions happen with some of these more complicated cases, and some of the uncertainties, particularly around let's start with the early stage. So with the adjuvant or neoadjuvant, in the neoadjuvant or adjuvant setting, how are you determining which routes to sort of go there, particularly with 1A, because you touched on it.
Yeah.
So how do you make that decision?
So ideally for patients with early stage disease, I would even argue later stages of disease, multimodality care, multidisciplinary care is going to be really important. And so, having those tumor board conversations, those multidisciplinary conversations or conferences where your case is presented in front of not only a medical oncologist like myself, but a surgeon, a radiation oncologist, a dedicated radiologist is going to be really important. And so I think the way that the field moves forward is together. And we're learning that if you give not only surgery or only radiation, but if you also start to include some of these medical treatments and drugs, not just chemotherapy, but targeted therapies if you qualify early in stages of disease, you can help patients live longer and reduce the risk of recurrence. But you're not going to be able to deliver it unless you've brought up that conversation or you've brought up the patient's case in front of the surgery tumor board, right? Your surgeons have to be on board. They have to know, hey, I guess there are improvements and updates for even stage 1 disease for patients, right? So I think that's really important to have those conversations even before a plan has been made.
And when we're thinking about even later stage, we're seeing a lot more of what you're talking about too, and we did touch on this a little bit earlier about these combination therapies to treat disease. What does that look like?
Yeah, so for stage 4 disease, traditionally the backbone, the staple of our treatment has been medical drugs, and that's what we call systemic therapy. That's what I give: chemotherapy, targeted therapies, immunotherapies, maybe even antibody drug conjugates, drugs on clinical trials. That's really been the staple, and that truly is the backbone of how we control, right? I said the control word, control stage 4 disease. But one of the questions that we have been looking at as a community, there's been a lot of evolving research happening, is it's deceptively simple. It asks a question: for a patient with stage 4 disease, can we do more than just drug therapy, right? And what do I mean by more? I mean pulling in local therapies like radiation, or surgery even, for patients with stage 4 disease. And this is a relatively new concept. In 2016, there was a lot of interesting data that was coming out for patients, and even more now in the 2020s, just recently some data from my own institution late last year. The reason why we're asking this question is because our drug therapies are getting so much better. And that's because we're learning how to personalize our treatments for lung cancer. And as our drug treatments get better, as we're truly personalizing, understanding the biology of the lung cancer, patients are getting better responses on their scans. They're actually doing really well. They're living well. They feel well. They look strong. And so then they ask a question, what else can I do? If I still have some leftover disease on my scans, is there an opportunity to pull in radiation? Is there an opportunity to pull in surgery? And this whole concept is called local consolidative therapy, or LCT. It's actually one of the most common consults that I get in my clinic every week. I see probably 1 to 2 cases of patients coming asking this question, can I do more than just the drug treatment that I'm on? And so my job is to make sure that they've maximized their response on their drug, right? And then to also really talk with the patient about what are their goals, what's their overall health, are pulling in other treatments like radiation or surgery truly going to be in the best interest with their quality of life, consistent with their goals, and then I'll have them meet several other colleagues in radiation and surgery to discuss their case.
Yeah. So there's a lot of chatter amongst the patient and caregiver community and in the healthcare community to some extent about, particularly in late stage patients, about sort of attacking the mothership, if you will, so the primary tumor.
Yep.
Is there any research to support that removing, either with surgery or radiation, what would be considered the primary tumor helps to control the disease?
Yeah, so an example of a trial I'll give is the North Star trial. So the North Star trial was a phase 2 trial. The data was just presented at the ESMO European Society of Medical Oncology conference in November. And what they looked at was patients with advanced stage disease, stage 4 disease, that was EGFR positive. EGFR is a very common AGA, actionable genomic alteration, that many patients with non-small cell lung cancer will have. On this study, the patients were put onto an oral drug called osimertinib, a very common targeted therapy that's chosen for patients in this disease state. And they had to have been on the therapy for a certain amount of time. So they started with drug therapy first. Again, that's really the backbone. They had to be on it for about 6 to 12 weeks. After 6 to 12 weeks of being on the drug, they got a scan. And if they had some response to the drug or their disease was stable, then they were randomized to either just stay on the drug and continue that, which is our standard of care, or have their case presented in front of a surgeon, in front of a radiation oncologist, and ask, okay, how many sites can we see on the scan now, and could they be consolidated? Could they be attacked or treated with radiation or surgery? And what we saw, and sort of the key takeaway from this study, was that patients who had radiation or surgery that were on that arm and they continued on the osimertinib, they actually had longer control, longer ability to stay on their osimertinib than patients that didn't have that. And so that's what we call progression-free survival, meaning their scans looked very well, actually, and longer than patients who were just on the osimertinib alone. And so what that tells you is you may get better drug control, that there is an opportunity for surgery or radiation even in stage 4 disease if those areas are treated. And so I think that's something to consider.
And does that trial extend beyond an EGFR patient?
Yeah, there's a similar trial called the Bright Star trial, and that's for patients with ALK disease. I think where it gets tough is, you can't necessarily have a dedicated trial for every single actionable genomic alteration. Remember, I told you there's more than just 2. And some of those are very common, like EGFR, and some are not so common. Some are in about only 1 to 2% of cases. And so one of the questions we ask is, can you extend this principle to other biologies? And so I think really I have a rule of 3 for LCT. It's got to be the right patient case at the right time with the right team. And it really takes all 3 in a very thorough evaluation before you can move forward with something like that. And so I'd encourage you to talk with your oncology team. If your oncology team wants to refer you for a second opinion to another center or institution that does that, talk with them about that referral.
I think this North Star study was one of the most exciting things for me, having been in this for so long and having been questioned by people for so long about why aren't we, these are people who are diagnosed later stage, like why aren't we just going and taking that sucker out and let's just, see what happens. And we're finally at a place where they're looking at it. And I think it's an important development for a lot of people with the trifecta, like you said, having all of those stars
all together
sort of align. Yeah. So we've talked a lot about biomarkers, but we know and proteins, PD-L1 or whatever, but we haven't talked a lot about people who don't have any of that, and what that might look like for someone diagnosed.
Yeah, actually did a talk maybe about 1.5 years ago, 2 years ago, patient-centered talk, kind of like this, and everyone broke up into the different groups. There was like the EGFR group and the ALK group and the KRAS group. And then there was, I'm using a lot of abbreviations today, so forgive me, but there was the FOMO group, the feeling of missing out, where they didn't have it, right? And then the next year, actually, they created that group for patients that don't have AGAs or actionable genetic alterations, and I love that they did that.
Yeah.
I don't want you to feel like there's no hope if patients don't have an actual genetic alteration. I feel very strongly about that. Immunotherapy can work really well still for patients that don't have an actual genetic alteration. Second, our definition of biomarkers that are targetable, that's evolving. Just over the last year and a half, we now are using newer biomarkers that now we can match with the drug therapy and their antibody drug conjugates, and we can talk about that. And you won't know unless you've been tested for it. I can't tell you the number of cases I've had over the last year and a half where I'm like, let's go back and let's look and see if maybe they've got this protein biomarker that's being overexpressed on the tumor. And we find it, and we match them with a relatively targeted type of drug, which we call antibody drug conjugates. So don't lose hope. There are options. There are still clinical trials, and current standard of care therapies like immunotherapy can work very well for these patients.
Let's talk about ADCs.
Yeah. So the way I describe it, antibody drug conjugates or ADCs, I call it sexy chemo or targeted chemo, okay? So the thought is that it's sort of made up of three different parts. There's an antibody that's on it, and it's going after a protein that may be overexpressed, that's really high on the surface of the cancer cells. And with it, it's linked to a payload, a very high dose of a chemotherapy. This chemotherapy by itself, at the level that it's at, normally your body couldn't tolerate it, it'd be too toxic. But what it does is this antibody brings along this very high dose of chemo and it drops it into the cancer cell specifically because it's found a target, it's found an elevated protein level on the cancer cell specifically where it can drop it into. And that's why it's smart chemo, that's why it's targeted chemo, that's why it's sexy chemo. The reason I keep saying chemo is because you can still have a lot of chemotherapy-like side effects with it though. Maybe not at the same degree as some conventional chemo, but you may still have hair loss or alopecia. You may still have some GI side effects. Blood counts may still get low. And so patients, when they sign up for antibody drug conjugates, they get really excited that I found something targeted, but you may still have some of those chemotherapy-like side effects. You need to be counseled on it. You need to be educated. And you can get through it as long as you're aware, right? As long as you're aware, as long as your teams are aware. But if the counseling isn't done right, then it could be a complete failure.
So I'm glad you brought up side effects or adverse events, and I know the people who are regulars at this programming are, a lot of them are no stranger to this. How important is it for patients to report their side effects to their providers? Because quite often, too often, I've heard of people suffering for a long period of time because they're terrified that they're going to be taken off therapy.
It's huge. Please tell us early. You aren't bothering us, I promise. If you tell us about a side effect or something you're worried about, it's better for us to know earlier because that's an opportunity for us to intervene. So for example, for immunotherapy-related side effects or immunotherapy-related adverse events, if a patient's on immunotherapy, it's better to know earlier because we can not only stop the drug and not give it to you for a little bit, but also give you steroids. We've seen from data, from research, that the earlier you intervene, the earlier you give something like steroids to calm down the immunotherapy, to calm down the immune system from what's happening, the overreaction, those patients do better. They are able to live longer. They're able to get back on their therapy sooner. And so please bother us early. It's actually much easier for me to know about something in advance than to try and be reactive much later.
Yeah. And I think it's important for people to know, too, that it doesn't always mean you need to come off that therapy. To your point, you might need to take a break, calm everything down, and then revisit how you go back on. I see you. I think it's working.
You recommend somebody who's listening tonight, online or in the room, and they learn something new from you. How would you recommend them approaching their oncologist? Because I have a feeling that a lot of people don't want to question their oncologist.
Yeah.
So how would you recommend them approaching their oncologist saying, hey, I was watching in the living room, and would this be a fit for me?
Yeah, I actually love this question. And this is my whole area of research and interest is patient education because, you gave this example of how busy community oncologists are. So community oncologists actually make up the majority of oncologists that are providing really amazing cancer care for patients who may not have access to an academic facility, who may not be able to travel that distance. And so they take care of a lot of patients. At the same time, they have to keep up with everything, right? It can be really hard. This is an opportunity, I think, for patients and families to say, hey, listen, I heard about this. What do you think? Because in medicine, we have this continued education. That's why we go to conferences. That's why we have all these meetings. That's why we have board exams. You have to stay up to date. And so I think patients can actually be a partner. And so if your oncologist does not feel like, or you feel intimidated about being a partner in your care, I would challenge you to think about maybe finding another oncology team. There should be no shame. There should be no intimidation about asking questions. I always tell my patients, write down questions. We can talk about it. It's really an opportunity, I think, to really develop a partnership and have that empowerment. I think empowered patients, I actually talked to a patient about this. They don't need to know everything. They just need to feel included. That's what empowerment means to me. That's what I think. You don't need to know everything. You just need to feel included. And so if you don't feel that from your team, I think that's an opportunity to reevaluate and maybe find a new team.
Yeah, go ahead.
At these community hospitals, if they don't have a tumor board, if they don't have that option's not on the table.
Yeah, and so I think this is another opportunity for organizations and advocacy groups as well to maybe connect community oncologists with academic oncologists like myself. I do a lot of talks actually where I go out to the communities and I meet different oncologists and we talk about things. I tell them about, hey, there's a really exciting trial that if you find patients like this, please refer them to me. And so I think it's opportunities for all of us as a community to really step up, whether it's through patient advocacy organizations, whether it's through some of the bigger medical organizations like International Association for Study of Lung Cancer. It's a huge unmet need. You're absolutely right, because not everywhere does have specialized tumor boards.
Yeah, so I want to touch on two things. One, something you said about empowerment and people, like not all people are empowered the same, right? Some people like a little bit of information in real time as they need it.
Yep.
Some people want the whole kitchen sink. They want to know everything there is to know about what's happening now and what, could possibly
Yep.
happen on 12 different roads in the future, right?
Yep.
So I think you hit the nail on the head, and it's important to be able to have those conversations with your providers and share with them what you need to know and when you need to know it. We can also help, again, at GO2 with sort of, you guys have heard me talk about the bite, snack, and meal size options
I like
for education and information that we can give you depending upon where you are. And then to touch on, Andrea, on your one of your questions about community centers where there, might not be tumor boards, or the provider themselves might not have access to all the information. This is where second opinions come in, and it's also a place where GO2 and our navigators and the folks on our helpline can help you regardless of where you are. We can help connect you with second opinion referrals to doctors like Dr. Singhi. And that doesn't mean you have to go to Houston for your appointment, right? It doesn't mean that you have to go to Stanford for all of your appointments. You can be in Eastern California, 3 hours away, have a second opinion, over here with someone who this is their area of expertise, and then take that treatment plan. That doctor will work with your local provider so that you can be treated close to home. This happens all the time.
Yeah.
And I think, unfortunately, a lot of folks don't know that because they take it, sort of from their provider. Like,
Yeah.
no, this is just what we're doing. And without really looking at your options, because lung cancer 20 years ago was complicated. And now it is such a complex
It's very
disease.
complicated.
Yeah.
It's also a privilege, too, that we have these complexities, right? Because it means we have more options. And
Yeah.
so I mentioned a lot of our trainees, and so I'm very privileged where almost every month now I'm saying, oh, did you hear about this new FDA approval? Did you hear about this new drug
Yeah.
for patients with lung cancer? I bet you the myeloma doctor didn't get to tell you that, right? So it's a privilege to say that we have options. But with options comes complexities, comes nuances. The other thing I'll touch on, too, about second opinions, sometimes even just getting reassurance from an expert in the field. You don't have to have a complete blow up and change of your plan. But I can't tell you the number of times where I've seen patients where I provided reassurance and that comfort speaks volumes where they return home. So it doesn't need to be a complete change in plan. Reassurance can also go a really long way.
Yeah, I love that. Oh, I thought I saw you raising your hand. No? Somebody is. Oh, hi, Simon.
Have to go across state lines. I mean, can you do it online without having to fly to
Yeah,
Texas?
telehealth is really difficult. Right now, it got much more liberalized during the COVID pandemic, and then we've seen these changes to the point where now I am licensed in a few different states, but only a select number of states. So it really depends on the physician's license, if they have a license in your state. And that can change almost every couple of months, honestly, in terms of what they allow or they don't. And so I'm constantly asking my schedulers, am I allowed to see a patient in this state? Am I not allowed? Do I need to apply? It's very complicated. But I hope that one day, yes, telehealth will be much more accessible, like the way it should be. But it's not perfect yet.
Yeah. This is where advocacy from a legislative standpoint
It'd be huge.
comes into play. I do want to jump into patient education, and I am trying to be mindful of time. But from a cancer standpoint, we had a pretty big win recently as it related to multi-cancer early detection testing, and I think that's a first step into some really exciting changes, right? That will positively impact. So instead of right now, when we think about screening for cancer, it's per individual cancer. You get your colonoscopy, you get your mammogram, you get your PSA, you get your low-dose CT, right? But this is looking at a blood test that can detect, multiple different types of cancer, hopefully early and all at one time. It's an evolving place, but it's definitely a step in the right direction when we think about innovation and advancements in the way we are finding cancer early, because we know the earlier we find it,
Can definitely save lives.
So I want to touch on patients and playing an active role. So we've touched a little bit on empowerment and education, but what we haven't really touched on, I'm just going to ask you the question, why do you think it's important that patients are empowered and educated and activate around their diagnosis?
Yeah, I mean, I think the simple answer is that the outcomes are better. I think patients that truly feel included, that feel like partners in their care, they're going to do better. They're going to derive more benefit from their therapy. They're going to live better as well. They'll have a better quality of life. I strongly believe in that, and that's why I spend so much time doing this online and offline, if you will. Again, I just want to emphasize, though, that empowered doesn't mean you have to have the knowledge about everything. It just truly means that you feel included in your cancer care.
Do you notice a difference with the people that you treat for those who do activate or educate around their disease? What does that look like in your clinic?
Absolutely. So I mentioned I see a lot of patients under the age of 50. Probably more than half of my clinic is under the age of 50. And my patients are some of the smartest people that I have met. They are very well educated. They're very well read. They'll come in with very nuanced questions. One time I had a trainee with me in the room, and I had a new patient that I was seeing and their family members, and actually brought in slides from a conference that I just come back for, and we were going through the slides and the data and the curves, and we were going through it. So we spent almost an hour and a half in the room just going over all the data and unpacking it, right? So that's the example of, I think, like a super empowered patient and their family where they want all the granular details so they can make that decision, right? But then there's also patients who ask questions as things go. I really like how you said the snack, the meal. You have to remind me what you said.
Bite snack meal.
Bite snack meal. I think that's incredible.
Yeah.
But it also is a big onus on the oncology team to recognize it and make sure that they deliver that information based on how the patient and their family wants it.
Yeah.
So there's no one size fits all for the empowered patient is what I would say.
So what role, I mean, some patients, particularly at diagnosis, they are overwhelmed with the fear, the uncertainty, all of that, and maybe just don't have it in them, right? So what role can a care partner or a family member or a friend play in the education and empowerment piece?
Yeah, I mean, I think having just another set of eyes, another set of ears in the room is huge. They've done studies on this, not even for cancer care. So just going to a regular medical appointment, after you leave the room, you only remember about maybe 40% or less of what was said. So a lot of it is forgotten. And then whatever you remember, about half of that is probably wrong. So that's wild to me, right, when you think about it. And then imagine cancer care, where they're throwing all these different new terms out. I threw out probably, I don't know, 50, 100 different abbreviations in our 1 hour here.
Yeah.
How is someone going to walk away with that and walk away with it correctly? So that's why you need another person there, someone to help take notes, someone to listen. I think it's huge. Yeah.
What is, oh, yeah.
Where is the fine point that, or the right, where is the fine point or a balance that if you keep reminding the person the lifestyle, some of these things, that it might not become counterproductive because then the person hears about the diagnosis kind of every day, the conversation. How would you handle the balance?
It's really hard, to be honest. The oncology team has to very quickly learn the patient in front of them and what they want to know. I have some patients that want all the details, all of the medians, all of the averages, and I have some patients like I don't. I have some patients that want to see scans. I have some patients that don't want to see their scans. The only way to know is to ask, to be honest. And sometimes I encourage, if I can tell that maybe the care partner wants something different than the patient, I will actually bring that up. I'll say, hey, listen, I can tell that there are sort of two different opinions here in terms of what you want to know, how much you want to know, how you want it delivered. I want you guys to go home and have a conversation about this. What is the way for all of you together to navigate this? Because we see it all the time. I see it all the time.
Yeah, agreed. Just doing a look, quick check-in, Michelle. Good? So,
It's coming down.
I know it is coming down. It's, yeah. When we opened, I talked a little bit about Dr. Singhi and his online presence. And I know I've recommended you all go and follow him over the last several months. Do you get feedback from people, from your patients in clinic who follow you, and what do they say? How is that helping to impact their day-to-day?
Yeah. Well, I'll say a disclaimer first. Like, you shouldn't get any medical advice from online. I feel very strongly about that. Talk to your oncology team. Get those second opinions in person. I think that's huge. So what I do is very general education, awareness, just general empowerment for patients. And I do get stories, not even from my own patients, but I've gotten messages from families, from patients. Some examples that have stood out. I had a younger patient that was following me, not my own patient, who messaged and said, my kids are 10 and 12, and yeah, 10 and 12. These are the conversations that I have to have in clinic with my patients. How do they, discuss this diagnosis? And she told me, or she messaged me, she said, because of your Instagram page, I was able to sort of have those conversations with my family. I was able to show them that there is hope in lung cancer, and it's probably one of the most incredible messages I've gotten. And so being able to facilitate a conversation with their family about a cancer diagnosis was huge. And sort of other examples I've had, because of videos that I've done, I actually did a video about how to navigate asking your oncologist for a second opinion, because it is awkward, right? If some people are like, oh my gosh, I feel like I'm going to break up with my oncologist, and this is really awkward to navigate, right? And so I said, okay, let's just go through 5 tips on how to navigate it and what to do. And somebody watched that video and they said, you know what? Like, because of that video, I was inspired to go do it, and I did it. And because of that, I got a second opinion. I actually found out about a clinical trial, and I got onto a clinical trial because of one video. So that's the power, I think, of community, the power of education, and really having that opportunity to empower patients and their families.
Yeah, I think one of the things that my mom, who, I think most of you know, was a founder of this organization. One of the things she said back in 2006 was, if I can help even one person, then it's all worth it. And I think one of the things you do so incredibly, extends well beyond outside of just the 2 examples you gave, but you use plain language to explain really complicated stuff. Mm-hmm. So how important is it for a patient or a person who is in their doctor's office and the doctor's talking way up here to just say, hey, doc, can we bring this down to a level that I can understand?
I think it's huge. But at the same time, it is not a skill set that we learn in medical school. There's no how to explain in patient-friendly language 101. We're taking so many other courses. There isn't enough time. They're trying to make med school even more abbreviated, more expedited. And so there really aren't those opportunities to traditionally and formally learn how to do that. And so not everyone has that skill set. And that's why I think there's an opportunity for people that are interested in this, that enjoy doing that spend a lot of time on research and that to do it. So that's why I do that, is because not everybody has that skill set, and there is no formal course to learn it.
Yeah, very true. Okay, what is, we're at time. What is the one thing you most hope people take away from this conversation, and what is your one message of hope for the future?
Yeah, I think the biggest one today is just biomarker testing in general. Biomarker testing is continuing to evolve. Biomarker testing should be comprehensive, right? And so if you've had biomarker testing, you really want to make sure that, was it comprehensive? Is it up to date? I think that's a really big one. In terms of hope, I would say, just as much as we've mentioned how much, the therapeutics and the drugs have really transformed for patients with lung cancer, so has really all the research that we're doing that's dedicated to improving quality of life for patients. That's really a big passion of mine too. We don't just want patients to survive, we want them to truly live. And I think there is a nuanced difference there. And sometimes we get so focused on those survival curves that we forget about that lived experience. And I think that's where the hope is. I think that's where the excitement is. And I think that's the way that the field should move forward.
I love that. Thank you so much for coming and talking to us.
Me.
It's been a ton of fun. We hope you'll come back. Maybe we'll come out and do one in Houston somewhere there locally for all your folks to come and hear you talk in a forum like this. Couple of housekeeping items. March 10th is our next Gathering Hope. So don't hesitate to join that meeting if you haven't before, and we welcome you back if you come regularly. Michelle moderates that peer-to-peer conversation where you can learn from one another, share some of those lived experiences and those stories. And then our next living room's on March 17th, and it's a person's guide, a patient's guide to understanding clinical trials. And we've got Dr. Jorge Nieva from USC coming up to have that conversation with us. You guys know I'm a huge fan of clinical trials, and as Dr. Singhi said, always keeping them not just as a back pocket option, but as a good option at any point during your care. So that is March 17th. A huge thank you again to Dr. Singhi, to all of you in the room, to those of you watching live from your own living rooms, or those of you coming back and watching post-live after. We're so grateful for you for being here. And don't hesitate to reach out even after the programming with any questions you might have about this. Big thank you to Penn Media for coming and setting up and making it so we can bring this programming to you live every month in your living rooms. Want to also thank our supporters. I have to read this because, as you guys know, it's a pretty long list, and without their support, we would not be able to bring this type of programming to you. So Abbvie, Amgen, AstraZeneca, Bayer, Boehringer, Ingelheim, Bristol Myers Squibb, Foundation Medicine, Genentech, Johnson & Johnson, Median, Merck, Novartis, Novocure, Regeneron, Revolution Medicine, Summit Therapeutics, and Takeda Oncology. Thank you so much for your support, and we'll see you next month. Thanks, everyone.
So I'll be brave if you're brave. I'll be brave, but only